In today's video, we'll discuss about chronic myeloid leukemia. So, first of all, it is a myeloproliferative disorder characterized by extreme proliferation of myeloid series of cells in the marrow with fairly normal maturation process. So what we see is there is increase in the proliferation of the myeloid series of cells, okay, but the maturation is normal. So we can also now we'll consider the pathophysiology. Now what really happens is there is chromosome 22 and there is a chromosome 9. Now BCR gene is present on chromosome 2 and ABL on 9. This is an important thing that you must remember and is often asked in questions. So just remember this way. In Hindi, we call 22 as 22, so BCR gene is present in chromosome 22. Now, what really happens is there occurs a translocation of the gene BCR over the chromosome 9, due to which there is a formation of BCR-ABL gene, okay, of 9 over 22. So this is basically the whole lesion follows a natural course, but the blastic phase is the last or the terminal phase in which there is blastic crisis. Okay. Now coming on to the clinical presentation of a patient who is suffering from chronic myeloid leukemia. Now I'll just draw a person here to make it easy to understand. So yes. So first of all, the person will have anemia, weakness, pallor, dyspnea, tachycardia, then fever and perspiration, hypermetabolism, weight loss, anorexia, night sweats. Also, the person will have bleeding tendencies. Epistaxis, splenomegaly, bone marrow hyperplasia. Now, coming on to the important investigations, first of all, in the mean hemoglobin, it will be decreased. There will be normocytic, normochromic anemia. Then, mean WBC count is increased markedly. Then, platelet count is normal. Then, we will do the blood film examination, PBF. There, we will see granulocyte precursors increase in the absolute count of the basophils, eosinophils, also the nucleated RBCs, that is the immature RBCs. Also, now we can also do the PCR to see the ABL BCR gene. Then coming on to another investigations like alkaline phosphatase stores, vitamin B12 levels will be high. Okay. Then coming on to the oral manifestations. Over here in oral manifestations, we can mention about gingival hyperplasia, gingival bleeding, ulceration, jaw pain, loose teeth or extruded teeth, sorry, gangrenous stomatitis, mucositis. Now coming on to the treatment. Treatment of CML is very important and is usually asked. So first of all, in the symptomatic patient, what we will see is the lymphocytes that they will be increased slightly. Now coming on to the modalities. There are three treatment modalities. The first one being the drugs, then being the allogenic bone marrow, and then being the treatment of hyperuricemia by allopurinol. Now in drug treatment, what we have is imatinib. Now this is a tyrosine kinase inhibitor. Okay, this basically inhibits the enzymatic action of the BCR-ABL gene fusion. Now, second generation drugs, similar tyrosine kinase inhibitors. First of all, this is given in the dose of 600 to 800 milligrams per day. Now, second generation, we can mention about dasatinib, nilotinib, Okay, then the response is assessed by the hematological test. The cytogenic responses are also seen. Then allogenic bone marrow transplantation. In this, basically, when there is prolonged remission, this improves the survival. This should be done in the early chronic phase. Now, this is quite self explanatory. Now, what is the thing if blast crisis happens? This basically becomes the cause of death. However, the treatment will depend upon the identification of the cell type, the biochemical, cytochemical type. We can give tyrosine kinase inhibitors, kinase inhibitors, but there is a chance of 30 to 50% remission. So this completes the CML. I hope you understood. Thanks for watching.